Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is ART treatment failure in adults and adolescents, when and what to switch. And the speaker is Dr. Rajeeb Day. Dr. Rajeeb Day is working as a technical specialist, public health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Thank you, Sweta. Good afternoon, everybody. So my topic is ART treatment failure, adult and adolescent, and why to switch. This is basically taken long back under RDLS by Dr. Rivo and Anwar. So today's session is basically the recapitulation of that session. Yes, I hope everybody has responded to this questions. Under this session, we are going to know what are the responses that we are expecting after starting and retroviral therapy patient. Then when the patient develops failure, and what are the different technologies of failure like viral failure, biological failure, chemical failure, and what is the importance of adherence in terms of viral testing and then failure of first line therapy, and then what kind of second line therapy we are going to try. In case of second line failure, what first line ART regulation under the national AIDS control program.
सर आपका आवाज ठीक से नहीं आ रहा है. हेलो सर. हेलो नहीं
now?
Yes.
If it is not internet.
श्वेता मैम सर का आवाज आ रहा है ठीक है?
नहीं. Sir, have you put earphones or something? Can you try without earphones?
Okay. Now, is it audible?
Sir, it is audible, but your voice is cracking.
Voice is cracking, so it must be a net problem. So let me change.
Now it is clear. Now it is clear.
Shall I continue?
Yeah, please, sir. In case there is some disturbance, we'll let you know. So you can continue.
And then what should be between adherence and the testing and the failure of ART. Then if a person ultimately fails to first line therapy, what second line options we have under the National AIDS Control Program. And in case of second line failure, what third line options we have, and drug-drug interactions of some of the ARV drugs. Hope I am audible. Please let me know. Now,
yes, sir.
to know all this retroviral failure, we first need to know the progression of infection in a human host, and the HIV virus, which can be of T-trophic virus or M-trophic virus, and based on the trophism, the virus either get attached to CXCR4 gene on the CD4 cells for T-trophic viruses, and for M-trophic, it attacks the CCR5 receptor on the CD4 cells. Now, there are different ARVs developed to block these two receptors. One is enfuviritide, which is also known as a fusion inhibitor, and it prevents the attachment of the virus with the CXCR4 gene, CXCR4 receptors on the surface of the CD4 cells. And Maraviroc is another receptor blocker, which blocks the attachment of the virus with the CCR5 receptor on the surface of the CD4 cells. These two drugs are not available under the national program. So when the RNA virus, HIV RNA virus enters the cell, when it is the cell, then it downloads this RNA into the cytoplasm of the host cell, that is the CD4 cells, which is acted upon by the reverse transcriptase enzyme present in the virus, and it converts HIV RNA into HIV DNA. This HIV DNA conversion from HIV RNA is done by reverse transcriptase. So the different molecules that are being produced are NRTI, that is nucleoside reverse transcriptase inhibitors. Under the program, we have zidovudine, lamivudine, abacavir. Stebudine is phased out. And NTRTI, that is tenofovir. Half is there, but not in the program. It is available in the private sector. And we have tenofovir isoproxolate in the program. And NRTI, efavirenz, and nevirapine, which are also been phased out. Now, as the HIV DNA is formed, it gets inside the nucleus of the human CD4 cells, where it is acted upon by the integrase, an enzyme that integrate the HIV DNA with the host DNA. Now, if we can block this integration by the integrase inhibitors, then this integration will be stopped and the progression of the infection will be halted. So in the program, we have raltegravir and dolutegravir as integrase inhibitor. Now, after this integration, this is acted upon by mRNA, and long chains of DNA, viral DNA is produced, which are cleaved by the protease enzyme into daughter RNAs, which are packed inside the capsule and are been protrudes out of the cells. So if in the protease inhibitor we have under the program as atazanavir, ritonavir, lopinavir, darunavir. So these things, it is just a recapitulation. We have gone through this picture many times. Everybody must have gone through it. So let us now come to the different molecules, particularly those which are available under the national program. So under the NSRTI, it is reverse transcriptor, we have zidovudine, lamivudine, abacavir, and stebudine was there, but it is now phased out. Amtricitabine is there in the private sector, but not available under the program. The nucleoside reverse transcriptase inhibitors, that is NTRTI, we have tenofovir disoproxylate fumarate, disoproxyl fumarate, and tenofovir alphenamide, which is not in the program, but available in the private sector. Then fusion inhibitor, enfuviratide, which is also not available. And under non-nucleoside reverse transcriptase inhibitor, we know it is nevirapine and efavirenz. Both of them are being gradually being phased out. And integrase inhibitor in the program, we have dolutegravir and raltegravir. CCR5 entry inhibitor, maraviroc, is not available under the program. And in protease inhibitor, we have ritonavir, lopinavir, atazanavir, darunavir. And post-attachment maturation inhibitor, these are in the pipeline. So let us revise what is recommended under national guideline. Preferred drug is dolutegravir screening regimen for any PLHA weighing more than 20 kg and more than 6 years under the NSCB since July 2020. Now, why DTG? We all know there are many studies, and the most important thing is the safety and the efficacy. The efficacy-wise, DTG is the molecule which suppresses viral load fastest, and it can suppress the viral load within 1 month. Whereas the efavirenz-based regimen and other regimen can suppress the viral load only up to 3 months' time. So for any patient who is treatment naive, adult and adolescent patient, we are to use triple drug ARVs, especially from 2 different classes of ARV. So under the national program, it is an RTI backbone is non-thymidine, that is tenofovir plus lamivudine, and one INSTI, that is the dolutegravir. Now, for adult and adolescent more than 10 years of age and weighing more than 30 kg, the preferred regimen is TLT, that is tenofovir 300, lamivudine 300, and dolutegravir 50 milligram in a fixed drug combination as a single pill once a day at a fixed time every day. That is, a person can take the molecule at any time of the day, but the timing should be fixed for every day. That is, every 24 hours, the patient has to consume 1 tablet. Now, once we start a patient on antiretroviral therapy, what are the things that we are going to monitor? So in every visit, we know that we monitor the body weight, height or of children, and 4 symptoms of screening are done at every visit. For every 6 months, it is NCD, that is non-communicable diseases like hypertension, diabetes mellitus, or it can be symptom directed also. Because with the rotograph, we know there are some weight gain. So in case the patient comes with signs and symptoms of hypertension or diabetes, then we may not wait for 6 months. We can go for screening of diabetes and hypertension. And then laboratory evaluations are done based on the type of ART regimen that we are going to use. And it is done every 6 months or depending on symptoms. CD4 count, as we know, it is done every 6 months. However, under the recent guideline with the introduction of viral load testing, we can stop CD4 monitoring after the patient becomes virally suppressed and the CD4 is more than 350 when both the tests are done simultaneously. But it is not to be done in case the patient is having the HIV-2 because HIV-2 viral load testing tests are not available in India. So we have to continue CD4 count monitoring in case of HIV-2 infections. Now, viral load, as you know, in case of first-line ART, it is after 6 months of initiation of first-line ART, then at 12 months, and then every year we have to monitor the viral load. Now, CD4 count should be restarted if it is stopped earlier, if the patient has been switched to a treatment failure to a second line. That is when the patient has gone through virological failure, we can restart virologic CD4 monitoring. And whenever the treating physician thinks it is necessary for clinical judgment, CD4 test can be repeated at any time. And for patients on second line and third line, plasma viral load has to be repeated every 6 months. And here we need to know that in pregnant ladies, we have to go for a viral load within 32 to 36 weeks of gestation. Now, what we are going to expect after we start a patient on antiretroviral therapy? First response is that in the virological arm, we get the patient gets suppressed virologically. That is, the viral load would be less than 1,000 cells per cubic millimeter after 6 months of ART with adherence more than 95%. And after the suppression of the viral virus, the immunity will start recovering and there will be increase in CD4 count by say 50 to 100 cells per cubic millimeter within 6 to 12 months of initiation of ART in an ART naive patient. And after the restoration of the immunity, the patient's well-being will increase and the patient will be free from any opportunistic infection. So this is called as a clinical response to ART. Now let us discuss about the treatment failure in adolescent, when to switch and what to switch. So how do we suspect? We suspect with the occurrence of new OI or recurrence of previous OI or clinical event after 6 months of ART after ruling out IRIS, that is IRIS, and progressive decline in CD4 count. And if the viral load is unsuppressed, that is more than 1,000 cells per ml, and slow or no clinical improvement over 6 to 12 months of ART associated with stationary CD4 count despite good adherence, that is more than 95%. Now, how do you define treatment failure? Virologically, we define treatment failure as any viral load more than is equal to 1,000 copies per ml, and after 6 months of ART with adherence more than 95%. And immunological failure, we define having immunological failure if the CD4 count is 250 cells per cubic millimeter following clinical failure, or if the CD4 count is persistently below 100 cells per cubic millimeter. And it is though not a proper diagnostic entity compared to virological failure, because the CD4 count can go down, can be suppressed for minor viral infections also. Now, if we cannot prevent the immunological failure and virological failure, then ultimately, if clinical failure, if we do not send the patient to SASEP early, then this clinical failure is presented by new or recurrent clinical events indicating severe immunodeficiency there is age-defining illnesses can be there. And many here we need to remember that many stage 4 conditions may not indicate treatment failure, while some of the stage 3 condition may indicate treatment failure. So for example, uncompleted TB pleural disease, lymph node TB, esophageal candidiasis, recurrent bacterial pneumonia may not indicate treatment failure, while WHO stage 3 condition like pulmonary TB and severe bacterial infections may also indicate treatment failure. Now, to differentiate these new OIs or recurrent OIs, we need to differentiate it from migraines. And how do we differentiate? We differentiate on the basis of by documenting increase in CD4 count after 6 months of ART. Now, treatment failure refers to the loss of antiviral efficacy to the current regimen. Now, we need to know the chronology of development of treatment failure. So first thing to indicate the treatment failure is viral load. So it starts first rising exponentially as the time progresses. And if we cannot detect it, or if we cannot send the patient, increase the adherence of the patient or refer the patient to the SASAP and second line is not started, then the CD4 will start falling after some time. And still then, if we do not send the patient to SASAP or change the regimen, then ultimately the patient shows signs and symptoms of severe progressive OIs, almost at the time when the viral load becomes plateaued. So there is it is important to know, and it is important to tell to our patient also, because with the viral load monitoring, we get to know the patient is failing quite early in the disease, and when the patient may be free of any opportunistic infections, and he may be doing quite well. So when we say that you need to come for adherence counseling 3 times, and then we need to investigate you all the basic tests, and you need to attend to SASAP, the patient may not agree to, because to him it will appear that he is doing well without any sign and symptoms of any disease. So we need to explain to him, see, for example, today you are having viral load unsuppressed. It will take around 1 to 2 years time before you develop those serious OIs. So if we cannot prevent it, you will develop it within, say, another 2 years. Then only patient will comply to our advice to come to ART center 3 times or to take medicines regularly for the second viral load test after 3 months of adequate adherence. Now, viral load testing that we have said for first line, it is first 6 months of ART and then 12 months and thereafter annually. And for second line, it is every 6 months. And for PLHIV transition to, that is either substituted or switched, it is to be done at 6 months, 12 months, and then annually in case of first line, and every 6 months for patients on second line and third line. And for pregnant women, it has to be done 32 to 36 weeks of pregnancy, regardless of the duration of ART. Now, how do we confirm treatment failure? It is confirmed by the viral load testing. If it is more than equal to 1,000 copies per ml, during routine viral load monitoring, at least 6 months after initiation of ART, with more than 95% of treatment adherence for each of the last 3 months prior to viral load testing, we call it as a confirmatory test of viral failure. Currently, under the national program, we have viral load testing for the HIV-1 only, but for HIV-2, we need to depend on the CD4 testing and clinical monitoring. So the algorithm, we all know, it is time. So after the test, if the patient is having viral load less than 1,000 copies per ml, that is the ART is still effective in the patient, and we advise the patient to continue ART regimen and for routine monitoring test. Now, if the viral load is found to be more than 1,000 copies per ml, then counselor to provide step-up counseling package to the patient for 3 months. And after 3 months, if the adherence is more than 95% in each of the 3 months, then we proceed for conducting the repeat viral load test. And if the adherence is less than 95%, then again we go for step-up adherence. After the repeat viral load testing, after 3 months of good adherence, if the viral load is less than 1,000 copies per ml, then we continue the same ART regimen and monitor the patient routinely as per guideline. Now, if the viral load is more than 1,000, equal to or more than 1,000 copies per ml, then we refer the patient under e-referral for further evaluation. Now, before we before we say that the person has actually failed on an ART regimen, there are certain important areas that we need to investigate. Say, for example, treatment adherence. A detailed assessment of the adherence need to be made. The reasons for non-adherence need to be explored. And unless these reasons are identified, the patient will find it difficult to adhere to the not only adherence. First, we know that yes, the patient was not adherent to a particular ART regimen. Okay, fine. But why he failed to adhere, that we need to know. Otherwise, if the factors remain, then the patient will again be non-adherent to the newer regimen. Again, the patient will fail. So there is no point changing the regimen. So after knowing poor adherence, confirming poor adherence, we need to know the reasons for poor adherence, and then we try to resolve those problems. So, for example, if a patient is coming from a far distance and which is difficult to reach areas belonging to a remote area, then we may provide him with a multi-month dispensation of 2 months or 3 months to solve his problem. Now, this treatment failure can be due to different drug-drug interactions. Say, for example, there are many enzyme-inducing anticonvulsant present, which are prescribed routinely for epilepsy and also for different psychiatric disorders. And in presence of those disorders, say for carbamazepine, which is an important enzyme inducer of the P450 enzyme systems of the liver, so our ART regimen is going to fail. So we need to know this drug-drug interaction, and if there is any such drug-drug interaction present, which the patient need to take for some other reasons, other diseases, then we may either change the anti-epileptic drug to non-enzyme inducing one, or we may adjust the dose of the ART regimen so that the patient doesn't fail again on the new ART regimen. Then certain OIs and occult malignancies may also lead to decline in CD4 count, which may revert after treating those conditions. So these are the situation, this CD4 count we need to take into consideration in those situations where we decide failure or confirmed failure depending on the CD4 count and clinical presentation. Say, for example, in the case of HIV-2 failure, suspected HIV-2 failure. Now, it is important to note that compared to clinical and immunological monitoring, viral load monitoring provides an early and more accurate indications of treatment failure that we have gone through. Then identifying the cause of failure is important because deciding to modify or switch the ART regimen before switching, detailed investigations into ART adherence to be made and assess drug-drug interaction which might intervene with ART activity before taking a decision on switch. Now, management of PLHIV with unsuppressed viral load. When viral load test report is available, the line list of such PLHIV with unsuppressed viral load to be generated on daily basis from IMS. The list should be shared with counselor delivering services under package C to telephonically follow the PLHIV with unsuppressed viral load and call them back to ART center. Counselor should provide intensive support to improve treatment adherence. A minimum of 3 sessions, that is done every month or every 15 days, are recommended for step-up adherence counseling. And it is preferred that all counseling sessions are to be taken by the same counselor so that it have the consistency, continuity, and proper documentation of the issue resolution. Then 3 sessions should be conducted when the patient visits the ART center to collect his or her medication. And if the patient fails to visit or is on MMD, then counselor should can provide counseling, step-up counseling over telephone also. Counselor should use the Ready Reckoner and step-up counseling form to facilitate the process. In case PLHIV is not available to come to ART center, that I already said, and during step-up counseling, HIV testing of spouse or partner and children should be facilitated or ensured. Repeat viral load testing along with other lab investigations may be done once treatment adherence is more than 95% for 3 consecutive months. Here it is important that many a times you find that in other investigations are not being done before such a referral. So during the adherence, this period can be utilized for getting all those test results. Though all efforts should be made to get the appropriate baseline laboratory investigations done for switching during step-up counseling period, non-availability of these lab results should not delay the referral. And PLHIV who are recommended for change in regimen by SASAP should be switched to new regimen as soon as the SASAP recommendations are available. So as per guideline, With the report of viral load more than 1,000 copies per ml, e-referral should be made within 2 days from the ART center to the SASAP or ART Plus Center or the COE. And COE or ART Plus Center, after receiving such a referral, should respond within 1 week of receiving such a referral. And simultaneously, patients should be informed to come back to ART Center for regimen switch as recommended by SASAP. Same regimen to be continued until switch of regimen. That is, before the patient visit to the ART center for new regimen, before the preparedness counseling, the patient should continue to consume the previous ART regimen, whichever he is taking, on which the patient has actually failed. Now, these are certain counseling details that in session 1, what we are going to do is to assess adherence as explain and explain VL result, assessment of patient knowledge regarding ART adherence and viral load, assess the support system, that is caregiver are to be counseled adequately, the importance to visit for EAC, then identify barriers to optimal adherence like side effect, depression, addiction, work timing, mental health issues, stigma, etc. Patients' motivations to stay healthy and alive to be ensured, discuss with the patient and develop an adherence plan which addresses the identified issues, and remind about the next ARTC appointment and viral load repeat test schedule. And session 2, assess adherence since last visit, appreciate if adherence is optimal, review if strategies accepted in the previous session were implemented or not, discuss any new obstacles which have emerged, modify the adherence plan to tackle the identified issues, and remind about the next due date and viral load repeat test schedule. And in session 3, assess for adherence since the last visit, appreciate if there is optimal adherence, and review if strategies accepted in the previous session were implemented or not. Modify the adherence plan to tackle the identified issues, and if adherence is not adequate, plan further sessions with the patient and remind about next due date and viral load repeat test schedule. So these are the components of those step-up counseling, 3 step-up counseling. Now, plan for next VL. If adherence is more than 95% in each of the last 3 months, we plan for a repeat viral load. If adherence is not adequate, then plan for further session of EAC with the patient before repeating the viral load. Now, session after VL. If VL count is less than 1,000 copies, appreciate his or her success during scheduled visit and advise to continue current regimen and next VL test to be done as per guideline. If VL count is more than 1,000 copies or equal to 1,000 copies per ml, e-referral to be made to SASAP within 2 days of receiving VL report without waiting for patient to come. SASAP should review the case and share recommendations with the ART center within 1 week of referral. Simultaneously, patient should be informed to come back to ART center. Same regimen to be continued till the switch is done. PLHIV who are recommended for change in regimen by SASAP should be switched as soon as possible. Now, steps for SASAP referral. This is also a recapitulation. We have been doing it. For PLHIV requiring referral to SASAP, ART center shall share details of the patient with the COE or ART Plus Center, filling up the RRF form, that is request and reply form for e-referral. The details are complete ART history, WHO clinical stage, treatment adherence, serial CD4 count, serial viral load test, latest investigation result as indicated, that is CVC, biochemical parameter, etc. Other treatment details of the patient, photo of visible signs of ARV adverse effect, clinical conditions in PLHIV if available for review. Other clinical records, as for example, discharge summary or any other relevant hospital records. Why this other treatment details of the patient, latest investigation result and the photocopy of the visible signs of ARV side effects is important because, say, suppose the patient has developed rash with, say, zirconium, but this rash is stage grade 1 or grade 2, and we have stopped the zirconium and shifted the patient to say tenofovir or avacavir. So, if such a patient is referred to SASAP, and if there is suitable second-line drugs or third-line drugs cannot be, regimen cannot be formulated for the patient, then those previous drug with minor side effects can be recycled for formulating second-line or third-line regimen. So this is important to photo document all those visible signs and symptoms of ARVs for which these were discontinued in the past. Now, step 2, SUSEP coordinator or COE or COE data manager at ART Plus Center shall download the patient information and prepare SUSEP meeting format for review during the SUSEP meeting. In case teleconsultation is conducted, referring ART center should be informed in advance about the date and time of SUSEP to call the patient. Step 3, SUSEP will review the documents in absence of the patient and make recommendations in the SUSEP meeting format. Step 4, SUSEP coordinator or COE data manager, SUSEP coordinator of the COE or the data manager of the ART Plus Center shall share the recommendation of the SUSEP with the referring ART center in RRF. And step 5 is referring ART center should confirm the action taken to SUSEP by filling up the RRF. Now, treatment failure to first line ART. So what is first line, second line, and third line? The first line ART is a patient who is naive to ART, receives for the first time is the first line ART for that particular patient. Second line, the second line ART is the subsequent regimen which has been recommended for the particular patient after the failure of the first line ART is the second line ART for that particular patient. And third line is the subsequent regimen used in sequence immediately after second line therapy has failed is the third line for that particular patient. Now, substitution versus switch, we know in case of side effects, adverse effect, or drug-drug interaction, a single molecule is changed, which is called as substitutions, whereas switch means following treatment failure, when the entire regimen is changed, it is called switch. Any substitution after 6 months should be preceded by viral load testing. This leads to understand to whether a single drug substitution is enough, that is viral load is less than 1,000 copies per ml, or whether the patient must be checked for treatment failure, that is if the plasma viral load is more than 1,000 copies per ml. When to suspect possible failure of the regimen, we know increasing trend of plasma viral load, that is more than equal to 1,000 copies per ml, static or declining trend in CD4 count, and new clinical manifestation or symptoms or signs worsening of existing condition. SUSEP can take a call on, that is the SUSEP recommendations can be to switch to prescribe second line or third line ART, regimen change not required, continue ART, the current ART, reinforce adherence and re-evaluate or evaluate for HIV-2. So these are the possible recommendations that SUSEP can make after going through the details of a particular patient referred to SUSEP. Now, steps in initiating second line ART, we know the defined treatment failure, that is, treatment failure is defined by virological testing in case of HIV-1. If the adherence to treatment is adequate and counsel and support for increasing the adherence, SUSEP will also see this and take decision on providing second line ART. And step 2, decide on NRTI component of the second line regimen. If zidovudine is used in the first line, then in the second line it would be tenofovir based. If TDF or abacavir is used in the first line, NRTI choice would be zidovudine based, and lamivudine will be continued because continuation of lamivudine is seen to reduce the viral fitness. That is, it make the virus more susceptible to the other potent antiretroviral drugs. And then in step 3, we decide on other component, that is either INSTI or PI. If patient has had an RTA in the first line, then INSTI, that is dolutegravir, will be preferred one. For patient who had INSTI in the first line, then we should give boosted PI, atazanavir, ritonavir in combination with NRTI backbone. And patient who had INSTI in the first line, give PI, atazanavir, ritonavir in the combination, use lopinavir in case of pregnant women and in case of HIV-2. We know well that atazanavir is not effective in HIV-2, so we need to give him lopinavir, ritonavir. And in pregnant women, there can be jaundice in pregnancy also, so we'll be confused with atazanavir if we prescribe it in pregnant women. So in these two cases, it is better to go for lopinavir, ritonavir. Now, patient education and agreement on a treatment plan, including follow-up and monitoring. We should include counseling for adherence, linkages to specialist care if needed, and follow-up monitoring plan. So expected resistance mutations with different ARVs, it is routinely not required in clinical practice. If somebody is interested, he can go through this. Let us skip it because these are already been taken in national NDLS. Now, second line ART regimen for PLHIV failing on NRTI containing first line ART. So NRTI are tenofovir, lamivudine, abacavir, efavirenz, or nevirapine. Now, hemoglobin, if it is more than 9 gram per TL, then zidovudine, lamivudine, and dolutegravir to be given. If hemoglobin is less than 9 gram per TL or past history of zidovudine-induced anemia, then we go for atazanavir, ritonavir, and dolutegravir. Both are OD. TTF to be maintained if the patient is co-infected with hepatitis B. And if the patient is on ZLE or ZLN, then tenofovir, lamivudine plus dolutegravir. So it is a FDC, that is once a day can be prescribed. And if there is any contraindication for tenofovir, we should go for abacavir. Then multi-NRTI exposed plus lamivudine, efavirenz, or nevirapine. Then we go for ATVR plus dolutegravir 50 milligram OD and existing NRTI backbone to be continued. And TTF to be maintained if the patient is co-infected with hepatitis B. Any PLHAV co-infected with TB or on rifampicin-based regimen, ATT regimen should receive BD dose of dolutegravir until 2 weeks after the completion of the anti-TB treatment and subsequently once a day to be continued. It is important here to remember that 2 weeks because this effect of rifampicin will take around two weeks time to go wash out of the body. So we should continue dolutegravir twice daily for 2 weeks after the cessation of ATT, and thereafter we can convert it to once a day dose. For those with HIV-2 or HIV-1 and 2 infection, pregnant women, or toxicity to ATVR, we use lopinavir ritonavir instead of atazanavir ritonavir that we have already discussed. And for failing first-line ART regimen, tenofovir or abacavir plus lamivudine plus atazanavir ritonavir, or tenofovir or abacavir plus lamivudine plus lopinavir ritonavir. If hemoglobin is more than 9 gram, we go for ZLD. Here, dolutegravir will be OD. If hemoglobin is less than 9 gram, then we go for darunavir ritonavir plus dolutegravir 50 milligram OD. And we should continue the existing NRTI backbone and TDF to be continued if the patient is co-infected with hepatitis B. And if the first line ART regimen was ZL atazanavir ritonavir or ZL lopinavir ritonavir, then the second line would be tenofovir, lamivudine, and dolutegravir 50 milligram once a day. And if the patient is contraindicated for tenofovir, then we can go for abacavir and lamivudine plus dolutegravir. And if the patient is multi-NRTI exposed plus lamivudine plus atazanavir or multi-NRTI exposed plus lamivudine plus lopinavir ritonavir, then the second line regimen would be darunavir plus ritonavir and DTG 50 milligram OD plus existing NRTI backbone. TDF to be maintained if the patient is co-infected with hepatitis B virus. Any PLHIV co-infected with TB and on rifampicin-based treatment should receive BD dose of dolutegravir until 2 weeks after completion of anti-TB treatment. So it is repetition, I think. Here, the points to remember is that PLHIV co-infected with TB and on rifampicin-based treatment received BD dose of DTG until 2 weeks after completion of TB. And any PLHIV co-infected with hepatitis B should receive TL if not already receiving entecavir. And for those with hepatitis HIV-2 and HIV-1 and 2 infection, pregnant women, or toxicity to atazanavir ritonavir, we use lopinavir ritonavir instead of atazanavir ritonavir. Now, second line ART failure and the third line ART regimen. All patients on second line ART need to undergo viral load testing every 6 months. The viral load algorithm should be followed based on the result. Patient with unsuppressed viral load should undergo enhanced adherence counseling and optimum adherence. Once the optimum adherence is achieved for 3 consecutive months prior to viral load testing, then we can go for viral load test. And workup for patient with suspected second line failure. Good adherence. It is the backbone of all those suscepting. Good adherence is important. Refer all cases with suspected second line failure to Center of Excellence or ART plus if adherence is good, that is more than 95% in each of the preceding 3 months. And there is no major OI. Poor adherence or major OI identified. Steps to improve adherence to be undertaken close monitoring to be done. If no improvement is seen after 3 months, the case should be referred to COE or ART+. Prescription of third-line ART regimen can be done by SASAP only at COE and selected ART+ centers. Decisions for initiation of third-line ART shall be taken by SASAP at COE or select ART+ centers after e-review. After SASAP has reviewed the patient and prescribed third-line ART, initiation and follow-up dispensation would be done by the parent ART centers as done for second-line ART. Henceforth, transfer out for initiation of third-line ART is not required. Earlier, we used to transfer out the patient for 6 months to the COE for initiation of ART. Nowadays, it is not required. It can be initiated at the parent ART center and it can be followed up with the COE, SASAP at COE or select ART+ center. Now, in the third slide, it is a very busy slide. So let us go through in the form of short form I will use, not the detailed one. So patient who has failed all 2 NRTI plus 1 NRTI as first line and now failing on PI-based regimen. So 2 NRTIs are either can be zidovudine, tenofovir, abacavir, and stemudine, and lemivudine would be there, and an NRTI that is nevirapine or efavirenz. If such a patient fails in first line, then we have seen earlier that we are going to give atazanavir, ritonavir or lopinavir, ritonavir. And in third line, we will be giving darunavir, ritonavir BD and dolutegravir OD because the patient was not exposed to dolutegravir earlier, and the existing NRTI backbone to be continued. And in case the patient is having hepatitis B, we should continue tenofovir. Now, patient who had 2 NRTI plus NRTI as first line failed on and are on insti-based second line regimen. That is the patient initially either on ZLN, TLN, TLE, ZLE, or abacavir, lemivudine, efavirenz, and in the first line, and in the second line, they have either zidovudine, stebudine, lemivudine, abacavir or tenofovir, and on DTG. Now they are failing in the second line. So DTG would be 50 milligram BT because the patient has already experienced DTG in the second line, which the patient has already failed. And darunavir, ritonavir, the patient was not exposed to, and it is given as BT dose. And existing NRTI backbone to be continued. And if the patient is having hepatitis B, then tenofovir need to be continued also here. Patients who had 2 NRTI plus PI in the first line failed on it and are on instibate regimen, that is either on atazanavir, ritonavir or lopinavir, ritonavir in the first line. And in the second line, they have received dolutegravir. So in the third line, dolutegravir 50 milligram BD plus darunavir, ritonavir BD plus existing NRTI backbone. Now, patients who had 2 NRTI plus PI as first line failed on it and are on an NRTI based second line. This was done earlier before the advent of integrase inhibitors, dolutegravir or raltegravir. So in those cases, what we used to do is that patient on atazanavir, ritonavir or lopinavir, ritonavir based first line ART are shifted to nevirapine or efavirenz based second line ART in those days when there was no dolutegravir. And then in those cases, now the recommended third line ART would be darunavir, ritonavir BD plus dolutegravir 50 milligram OD because the patient was never exposed to dolutegravir and existing NRTI backbone to be continued. Patients who had 2 NRTI and PI in the first line and failed on it and are on darunavir, ritonavir based second line regimen. The third line would be 50 milligram OD. Because the patient was not exposed to dolutegravir and darunavir, ritonavir twice daily to continue and existing NRTI backbone to be preserved. Now, everywhere we know if the patient is having HIV, hepatitis B infection, then the tenofovir has to be continued. Okay. Then the monitoring. Once we put a patient on second line on third line ART, the different monitoring to be done as per this table, that is hemoglobin or CBC at the baseline, first month, third month, 6 months, 12 months, 18 months, then 24, and then that is every 6 months. Then complete LFT on baseline, then at third month, 6 months, 12 months, 18 months, thereafter every 6 months. Then renal function test, baseline, third month, 6th month, 12th, 18th, 24th. Then fasting blood sugar, baseline, and then 12 month and 24 month. That is, it is yearly. Fasting lipid profile, baseline, 12 month, 24 month, that is yearly. Viral load testing, baseline, 6 month, annually, 6 months, 12 months, and then annually. And CD4 count baseline, 6 months, 12 months, 18 months, 24 months, that is 6 months. And if we stop it based on the CD4 and viral load criteria, then it will be stopped, and we can restart CD4 monitoring as and when clinically indicated, or when the patient is expected to go for a transition to some ART. The timing for CD4 testing, 6 months till CD4 count reaches 350 cells per cubic millimeter and plasma viral load less than 1000 copies. CD4 monitoring should be restarted for any patient if the patient has suspected treatment failure, that is virological failure, with this viral load of more than is equal to 1000 copies per ml, or if the patient has undergone a switch in regimen. The treating doctor can request for a CD4 test or viral load test when deemed necessary for clinical management and decision making. HIV-TB in second line or third line ART patients. TB is the most common why we know, and is one of the most common cause for death in HIV patient. Although tuberculosis must be treated appropriately and on priority, the context of second line ART and drug-drug interaction must be considered. So, for example, in second line or third line regimen containing PI, rifampicin cannot be used in combination with PI. If at all we want to use, then rifampicin need to be changed to rifabutin. But as of now, there is no rifabutin in many other places, so probably we'll have to go for change of rifampicin with other ATT in consultation with the expert. The dose of rifabutin during administration of ATVR or LPVR or darunavir shall be 150 milligram once a day for PLHIV more than 30 kg for the entire period of co-administration of anti-TB treatment and second-line ART. Now, whenever rifabutin is prescribed, instead of the usual FDC pack, individual anti-TB drugs without rifampicin must be dispensed to the patient as per weight band. So we all know that the ATT regimen, these are being provided to the ART center, are all 3 FDCs and 4 FDCs. So we cannot have this loose medicine in ART center, and we will be referring the patient to the TB center. We must collect the medicines for the patient and store in our center, ART center, but for initially, these have to be provided from the DTC. Some of the common side effects of rifabutin include orange-brown discoloration of skin, tears, saliva, sweat, urine, and stool during rifabutin administration. And this is also common with the rifampicin. If the patient experiences chest pain, muscle ache, severe headache, fatigue, sore throat, flu-like symptoms, vision changes, unusual bruising or bleeding, or nausea, vomiting, and or yellowing of the skin or eyes, further evaluations are required. Patients already on ATT and needs to be initiated on PI-based second line or third line ART, we substitute rifampicin with rifabutin if it is available for 2 weeks prior to initiation of second line ART, and this should be done to allow hepatic metabolism that is induced by rifampicin to normalize prior to initiation of PI containing regimen that we have already discussed while discontinuing BD dose of dolutegravir in presence of rifampicin. Initiation of anti-TB treatment in patient already on PI-based regimen. Substitute rifabutin for rifampicin within the prescribed anti-TB regimen for the start of TB treatment. And second line or third line regimen containing integrase inhibitor, dolutegravir can be safely administered with rifampicin, and the dose of rifampicin would be 50 milligram twice daily and to be continued for 2 weeks after completion of the rifampicin-based ATT. Now, in the absence of rifabutin, what other measures we can do is that we can change the ART regimen also if we want to keep the rifampicin in the ATT, because rifampicin is one of the most effective bactericidal medicines. So many specialists, infectious disease specialists wants to keep rifampicin to treat TB, in those cases, we can change the PI-based one into dolutegravir, and we can provide it twice a day. So management of side effects related to the second and third line regimen. So tenofovir, we all know that it usually gives rise to kidney, affects kidney, that is toxicity to kidney, and bone mineral density is reduced by tenofovir. So we can provide some calcium supplementation for prevention of those, and for CKD or kidney problems, we can go for titration of the dose as per the guideline. And we need to get the renal toxicity, we need to monitor renal function tests as per NECO protocol, and symptomatic management of minor side effects can be done. With dolutegravir, it is usually well tolerated, and some of the reports are insomnia, headache, but this is also not a major problem. Depression, suicidal ideation, very rare, and it happens particularly in those patients who have pre-existing psychiatric conditions. And weight gain is a concern, so we need to counsel patient before starting dolutegravir that they should modify their lifestyle, exercise, diet, etc., to be counseled before the initiation of dolutegravir. Then hepatotoxicity is there. For that, we need to monitor AST or LFT. Potential for increased risk of neural tube defect, which was found earlier, but nowadays it is seen that the increase in neural tube defect is no more than the those people who are on non-DTG based ART regimen. And there are some cases of hypersensitivity reactions, so we need to keep it in mind while prescribing dolutegravir. And we need to manage those side effects, minor side effects, symptomatically, and we need to get a consent, informed consent from the woman of reproductive age before initiation of dolutegravir because of the risk of neural tube defect, though it is found that with the latest evidence, it is found that it is not more than those people who are on ART without dolutegravir also. Now, atazanavir, ritonavir, we know the unconjugated hyperbilirubinemia and fat maldistribution, hyperlipidemia. It happens with all the PI inhibitors, but unconjugated hyperbilirubinemia is more common, is unique to atazanavir, ritonavir. And there can be increased bleeding episodes in hemophilics. The unique side effects of atazanavir include hyperbilirubinemia, and the patient may not want it because of cosmetic reason, but we need to reassure them that this is not going to affect you. And in case the patient is tolerating the yellowish discoloration, we should continue. But if the ALT, AST rises along with this yellowish discoloration, then we should stop beyond AST, ALT more than 5 times or 10 times. Then unique drug interactions involving atazanavir. In addition to all the drug interaction involving PI class, atazanavir has significant drug interaction with antacid, H2 receptor antagonist, and proton pump inhibitors. Then here a reference has been made to Annexure 5 for management of atazanavir induced unconjugated hyperbilirubinemia in the national guideline. So in case of antacid, we need to give atazanavir at least 2 hours before or 1 hour after the antacid or any buffered medication. Then for lopinavir boosted with ritonavir, side effects includes mainly GI. There is abdominal pain and abnormal stool, bowel movements, diarrhea, feeling weak or tired, headache, and nausea. In addition, patient taking lopinavir ritonavir should be monitored for possible liver problems. People who have liver disease such as hepatitis B or hepatitis C may experience a worsening of their liver condition. A small number of patients have experienced severe liver problem. So management is symptomatic for minor one, and supportive counseling and use of other drugs to manage gastrointestinal effects should be done. These symptoms improve after a few weeks. Monitor LFTs, lipid profile, and blood sugar regularly. And this is for all PIs basically. And lemivudine is very minimal side effects is expected, and some of them includes cough, diarrhea, dizziness, headache, loss of appetite, mild stomach cramps or pain, which subside once the patient keeps on continuing the medicine. And rarely it gives rise to rash or hypersensitivity reaction. nausea, pale skin, severe stomach pain, skin rash are rarely seen. And then the management is also symptomatic for minor one, and if in cases of third or fourth degree rash, we need to substitute it with the other NRTIs. Then darunavir, skin rash is seen with darunavir, uh, uh, and the severity of rash are similar to those with or without a sulfonamide allergy. Stephen-Johnson syndrome, toxic epidermal necrolysis, acute generalized exanthematous pustulosis, and erythema multiforme have also been reported. Other adverse effects can be hepatotoxicity, gastrointestinal intolerance, headache, hyperlipidemia, serum transaminase elevation, and hyperglycemia. These are also common to other protease inhibitor. Then fat maldistribution. And management includes symptomatic one if for the minor effect, and supportive counseling and use of other drugs to manage gastrointestinal effect, and monitor LFT and lipid profile and blood sugar regularly. Atazanavir induced unconjugated hyperbilirubinemia. The recommended prescribed dose of atazanavir is 300 milligram and ritonavir 100 milligram once daily. Isolated unconjugated hyperbilirubinemia is the most common laboratory abnormality associated with the use of ATVR. The onset of ATVR-associated hyperbilirubinemia typically occurs within several months, and bilirubin levels generally peak within 4 months, range from 1 to 8 months. An isolated elevation in total bilirubin should be confirmed as predominantly unconjugated by testing the indirect fraction of the bilirubin. Further investigation required in presence of elevated conjugated bilirubin or changes in serum hepatic transaminases and alkaline phosphatase. It is because many a time when the patient is taking atazanavir, we presume that all unconjugated bilirubin or hyperbilirubinemia is due to atazanavir, while it can be due to some viral hepatitis also. So we need to test test for other viral hepatitis before concluding that it is due to atazanavir. The management decision to continue depends on the associated increase in transaminases. Decision of whether to continue the offending protease inhibitor usually depends on how severe and noticeable the jaundice is and whether the patient is willing to tolerate it. That is, if the cosmetic problem produced by yellowish discoloration of the skin is tolerated by patient, then we can continue atazanavir if there is no transaminase increase. The PLHAV requires proper counseling on the development of yellowish discoloration of the eye that is not associated with liver damage, and it should be re-emphasized that this is physiological and not alarming. An alternative regimen is necessary only for patients who develop an unacceptable level of jaundice with grade 3, that is 5 to 10 times upper limit of normal, and grade 4, that is more than 10 times upper limit of normal in case of ALT and AST. Atazanavir-induced unconjugated hyperbilirubinemia. In case of hepatic insufficiency, dose should be adjusted. And in case of Child-Pugh A, we can continue atazanavir, but for Child-Pugh B and C, we should not continue atazanavir. Or in case of alcoholic liver disease, NASH, and other chronic liver diseases, we should avoid atazanavir. Atazanavir 300 by 100 milligram can only be used in patients with chronic liver disease in Child-Pugh class A. It should not be used on second-line patients with Child-Pugh class B or C. Now, for doing the Child-Pugh, we know we had to go for assessment of encephalopathy, grading of encephalopathy first, then whether the patient is having ascites or not, and the amount, the level of albumin, total bilirubin, and then prothrombin time and INR. So these things are difficult to remember. It is better to keep them on the table so that whenever such a patient comes, we can refer to these tables. So there are 4 grades of encephalopathy we know, 1, 2, 3, 4. Grade 1, we may not find anything, mild, or there can be mild confusion, anxiety, restlessness, fine tremors, slowed coordination, and then include drowsiness, disorientation, asterixis, that's the hepatic flap, and grade 3, somnolent but arousable, and there is marked confusion, incomprehensible speech, incontinence, and hyperventilation. Grade 4, coma, decerebrate posturing, flaccidity. So after scoring for hepatic encephalopathy, we should and other parameters like ascites, albumin, etc. We combine those scores, and if the scores are below 6, that is, it is in the class A, and we can continue atazanavir, ritonavir. But if the score is more than 7, then it is in either in class B or C, and we should not continue atazanavir. Dolutegravir, we all know that it has interactions with the cation-containing antacid and iron and vitamin preparations. So we should advise them to take at least 2 hours before or 6 hours after supplementation. That is, the DTG medicine to be provided 2 hours before the administration of such kind of antacids or vitamin or mineral and iron, or 6 hours after the supplementation. Rifampicin can decrease concentration of DTG, we know it, and for that, in prescribing DTG along with the rifampicin, we advise DTG 50 milligram twice daily instead of OD, and we continue it till 2 weeks after cessation of rifampicin. And in case of carbamazepine, also increase the dolutegravir to be increased to 50 milligram, or carbamazepine should be changed to some other non-enzyme-inducing antiepileptic drug. And then in case of metformin, dolutegravir tend to increase the metformin level. So the highest dose that is recommended for use in patient PLHIV who are on DTG regimen is 1 gram per day. And for all protease inhibitors as a class, major drug-drug interaction is possible with estomizole, cisapride, fluticasone, indinavir, and then simvastatin, midazolam, terfenadine, rifampicin, atorvastatin. So there are a huge list of drug-drug interaction, and it is not humanly possible to remember all the drug interactions. So we can refer to the Liverpool website of drug-drug interaction checker. It is a very useful one, and we get to know comprehensive drug interaction from that. So I would request everyone to consult that website, drug interaction checker of Liverpool. It is available. If you search it under Google, you will find it. And for prescribing H2 receptor blocker along with atazanavir, we need to administer atazanavir at least 2 hours before or 1 hour after the H2 receptor antagonist is taken. And the dose should not in 20 milligram twice daily. And famotidine highest dose recommended is 40 milligram BID. And in proton pump inhibitor is not recommended for ATVR. Other drugs, but if we want to use it, we can use it at least with a gap of 12 hours. Carbamazepine, there is possible increased concentration of carbamazepine. Carbamazepine dose reduction may be necessary. Concentration of PI may reduce substantially, and consider alternate ARV or anticonvulsant. If co-administration is necessary, consider monitoring concentration of both the drugs and assess virological response. Carbamazepine dose reduction may be necessary. Contraceptives, decrease in concentration of oral contraceptives is expected when co-administered. Oral contraceptive pill should contain at least 35 microgram of ethinyl estradiol. And buprenorphine, area under curve is increased, that is more than 66%. Non-buprenorphine active metabolite area under the curve is increased to 105%. Monitor for sedation and other signs and symptoms of overdose of buprenorphine. So the reduction of buprenorphine dose may be required, but in methadone, opioid withdrawal is unlikely but may occur. So those patients who are taking methadone, if they are put on atazanavir-based regimen, there can be opioid withdrawal. That is, the methadone level will go down and patient will develop signs and symptoms of all those withdrawal. In which case we need to increase the dose of methadone. So this much. I hope it was eligible because there are some internet issues.
Thank you so much, sir, and thank you for agreeing to take this session at the last moment. Any questions from the participants? Please.
Hello, excuse me, sir. I'm Dr.
Yes.
Shivakumar from JSIRT. Why the viral load assessment is not done for HIV-2 patients?
Because the viral load testing kits that are available in India is for HIV-1 only. For HIV-2 virus, the kits are not there in India.
Okay, so thank you.
In the program, at least it is not there.
Okay, and one more thing, sir. You know, when the viral load is more than 1,000 copies per ml, you have to refer through e-referral within 2 days. But we need the patient for all the basic investigation, latest investigation. So we have to call for the patient. Without the patient reporting, we cannot send within 2 days.
Yeah, actually what happens, doctor, actually, we are referring the patient only after the second, repeat viral load, right?
Yes.
So before repeat viral load, we already know the patient has already failed. No? In the first viral load, we got to know that the patient has already failed. Now, during the course of adherence counseling, we get enough time to go for all those basic tests. Say, for example, even after the patient has improved adherence, we do not know what will happen in the repeat viral load, but we can repeat some tests, no? At the discretion of the medical officer, you can repeat some tests. So on the third month of EAC, if we advise them to go for some tests, hopefully before the second viral load, that is the repeat viral load, we will be having all the reports in our hand, right, sir?
But ours is a PPP model and it costs about 4,000 rupees for all the tests, sir. So that's why we always, after the viral load failure only, we do.
Okay, then there is a clause in the guideline you will find the non-availability of tests should not prevent SASAP referral. It is ideal to refer the patient with all the recent tests, but if this is the situation that the patient will require 4,000 rupees, then probably it is better to wait for the result of the second test. And after that, if it is found to be unsuppressed, the patient should be referred immediately to SASAP within 2 days. And at the same time, simultaneously, we should go for the test. And whenever they are available, we should communicate it to the COE or the ART Plus Center.
Thank you, sir.
So there is one question in the chat box. Does CPT have interaction with any of ARV drugs?
Directly, it doesn't have, but there are many ARTs which has bone marrow suppressing potential. The CPT also has, and there can be overlap of side effects in the form of drug rash, which can be produced by zerovodin, which also can produce by CPT. So we had a class, we had a seminar on that, the adverse effect management. And if you refer to those recorded link in the YouTube, you will be going through all these things. So there are overlapping side effects, but synergistic effect are not seen that much. Some common side effects are there, definitely.
Any more questions from the participants? You can unmute your mic and ask questions. Yes, sir.
Good afternoon, sir. This is the Tirupati ART Center Medical Officer speaking, sir.
Good afternoon.
Hello.
Sir. Good
Hello.
afternoon, sir. Yes,
Good
please
afternoon,
go
sir.
on.
Sir, this is just a hypothetical question, just for my interest. In case some patient, let us say after 5, 10, 15 years, or maybe even 15, 20 years, he develops resistance to dolutegravir, what would be the second line for such a patient, sir? Supposing a person who has been having TLD from the next 15 years, let us say, and then he fails. What would be the second line for such a patient, sir?
So if a person is failing, say for example, consider the third line drug. A person who was on NRTI and an NRTI based regimen in the first line.
Okay.
Second line, dolutegravir based regimen.
Okay.
Third line, what we are providing? We are providing him with dolutegravir twice a day.
Okay. So that doesn't matter.
It has been seen in the studies that if you make it twice a day, it becomes effective. Yeah.
Okay.
And by that time, many new antivirals will come up. We are hopeful, is not it?
Yes. Okay. Okay. Thank you, sir.
So there's a question in the chat box. Do we have to stick to the time frame for referring failures to SASAP and starting the new prescribed regimen, as there is a lot more time taken at SASAP?
Yeah, so this is bidirectional. The ART center should report within 2 days of unsuppressed repeat viral load, should refer the patient to SASAP, and SASAP should also respond within 7 days of such a referral. So it is on both the sides that we have to follow the time frame.
Thank you, sir. Any more questions? Kiran, sir, meantime, can we run the feedback poll? Participants are requested to please take the feedback poll. There are 4 questions in all. Please answer all the 4 questions. Please feel free to unmute your mic and ask questions. You can also put them in the chat box. Participants are requested to please answer the feedback poll. So there's a question in the chat box. Patient is developing jaundice for TL plus ATV, RTV. What regimen should be given?
Yeah, so if it is in presence of ATVR, then we need to know whether it is conjugated or unconjugated. If it is unconjugated and the patient is asymptomatic, then we can reassure the patient to continue this because it is physiological. It is related with the antiretroviral atazanavir, and need not worry. It only gives rise to cosmetic inconveniences, but otherwise it is all right to continue because bilirubin will be increased, no, with atazanavir, we know it. And if it is unconjugated, then we know it is due to atazanavir. And if the patient is asymptomatic, then we can continue. Why to change? We can change only when this increase in bilirubin, that is unconjugated hyperbilirubinemia, is associated with say 10 times increase in transaminases or 5 times increase in transaminases. And if the patient is symptomatic or not, depending on whether the patient is symptomatic or not, we can stop change atazanavir. But if there is no increase in transaminases, if the patient is asymptomatic, we can simply reassure the patient and we can continue.
Thank you so
Hope
much,
I'm
sir.
clear.
Any more questions from the participants? Kiran sir, we can end the feedback poll. Thank you so much, Dr. Rajeeb sir, for facilitating today's session. Thank you to all the participants for patient listening. So can we conclude this session now?
Yeah, thank you all.
Thank you, sir.
Hello.